Hello, this module is about injecting insulin, and it's important to note that where you inject the insulin is as important as the type of insulin that you inject. I'd like to start by acknowledging with gratitude that this presentation was created on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations. I'd like to thank them for their stewardship of these lands over time in memoriam. So, injecting insulin. So I mentioned that you may think that you know the action of the insulin that you're injecting, but where you place that injection can really impact how the insulin is absorbed. So we'll talk about understanding the causes of suboptimal glycemic control that might be not something that you think of routinely, assessing for and managing lipo hypertrophy, and troubleshooting practical aspects of insulin injections. So we have many industries that use checklists. The airline industry would be a very good example where they need to check their plane before they take off, and so they go through their checklist of each thing. And often we do our medication, rights of medication, and make sure that we're giving the right amount at the right time, that we double check it. But we're not really doing the full checklist. So we need to make sure that we're using shorter needle tips, and if you're using an insulin pen in a hospital setting, then you're using a 5mm safety needle tip, but no longer than 6mm. So if you are in a position where you're giving insulin subcutaneously for a stat dose, you definitely do not want to be picking that 8 or 12.7mm insulin syringe, because that's far too long and it can impact the absorption of the insulin. We need to assess for lipohypertrophy, which we will review in this module. Observing the patient doing an injection with the force that they're using, and also observing yourself. We're not often told how softly we need to put the insulin in, and sometimes we overdo it and push in too far. And then if we are in a position where we're teaching insulin to a patient, and really every time you give an injection in the hospital to a patient, you are teaching them through observation. So it's important for you to know about site rotation patterns and making sure the patient is doing the same at home. And then advising to replace the needle each time. Of course, that's not an issue in the hospital. We never reuse needles, but in the home setting, when they don't have a safety needle, sometimes they are reusing those needle tips too long. So some of the things that affect absorption would be the choice of injection site. So intramuscular injections can lead to too much force and an increase in the absorption of the insulin. If the needle length is too long, then it can go intramuscularly, and that definitely impacts the time action profile of insulin. Lipohypertrophy, or lumpy bumpies, are basically caused, they're hard fibrous tissue that develops in response to reusing the same site over and over again. And we need to encourage site rotation. And the amount of insulin injected. So we'll review what is recommended for volume. So there's a couple of studies, the UK IT intervention or injection technique intervention, in a small number of patients, 75 patients, they basically used intensive education, switched them to a 4mm pen needle, and followed them for 3 to 6 months. And so before the study, 89% of patients were injecting into lipohypertrophy, or those lumpy bumpies that can cause insulin to not be absorbed properly. And only 20% were injecting into them after the study. And the A1C, or 3-month average, was improved by 0.4%. And when you think about it, metformin, glyburide, glycoside MR, any of the DPP-4 inhibitors, they reduce A1C by about 0.4, 0.5%. So this is no medication added, and it's reducing A1C. It also reduced the variability of, they have labile sugars, and their sugars go high at this time one day and low the next day, and that's because they're injecting into sites that can impact the absorption of it. And that fell by 40% in the patients in this study. And unexplained hypoglycemia also fell by 40%. So significant results in this study showing that where you inject is as important as what you are injecting. In another study of 116 patients, they were randomized into 3 groups, and they were given injection technique education as well as changing to the pen needle length, and it reduced their fasting glucose by up to 2.4 millimoles, reduced their A1C by 1%, significant change. 92% of the patients stopped needle reuse, and rotation errors were reduced to 0 from 27%, and there was no bruising seen either, whereas 29% reported that at baseline. So definitely showing positive results in educating patients on needle injecting insulin. So of course, if you're in a hospital setting or long-term care setting, anything where you are injecting the patient and they're not self-injecting, you're going to be using a safety engineered needle tip. And you can see here that this is an unused needle, so it doesn't have the red line and it doesn't have the locking mechanism as this does because it's actually been used. And on the other end, you can see that the cover has been automatically retracted and doesn't allow that second needle that allows the insulin to leave the insulin pen to cause a needle stick injury. So lipohypertrophy, let's talk a little deeper about this. Each time we insert a needle, it's a little trauma to the adipocyte tissues, which are the fat cells of the subcutaneous fat. Many tens of thousands of cells are damaged every time we put that needle in. So then when there's damage, the body does its job and activates a wound healing, bathing the areas with hormones, chemicals, and specialist cells to bring about healing. And that healing cascade takes place bathed in insulin. Insulin is a growth hormone, a growth promoting anabolic properties. So this is the only type of drug that you inject that can cause lipohypertrophy. If you're giving blood thinners, GLP-1s, none of them are insulin, and so they don't have that kind of catalyst to promote too aggressive of growth in the adipocyte tissue. And so over time, we keep going into that same area, and the wound healing causes those adipocyte cells to regrow larger and somewhat altered, and they have fat droplets on the surface. And so there's the lumpy bumpies that we're talking about. There are altered clumps of adipocyte cells form, and they develop what we call lipohypertrophy. So what are the consequences of lipohypertrophy? If we give insulin into the same spot all the time, it's not going to absorb properly, which means that they need to use higher doses, which is a higher cost, especially if they're paying out of pocket. They'll have greater glycemic variability because if we go from a lumpy, bumpy spot that doesn't absorb the insulin and our sugars go up, what do? We increase the dose, and now we take that increased dose and go into a healthy spot, and now they have unexplained hypoglycemia. Insulin has weaker glucose-lowering effects if you're injecting into lipohypertrophy because it can't absorb. And the insulin's absorbed with so much greater variability. So it's really not a good thing to go into the same spot all the time. And as nurses injecting people with insulin, we should be aware of where we are injecting. So here's some dramatic examples of some people with lipohypertrophy. And I'm choosing these because it's not only these lumps, but also it can be the tissues drying up and having concave, as is in the middle top representation here. And the gentleman that's on the far right bottom actually has injected for years in the same spot, either side of his belly button, and those are drastic lipohypertrophy representations, which may never go away. So it's good to assess ourselves and assess the patient if they're self-injecting on how deeply they're going in. So if the patient uses excessive force, and they're deeply dimpling the skin, or you are as a nurse, we need to make sure that it's not going intramuscularly. And that's the premise behind the shorter needle, is that the longer needle you have, and then you push harder, you can actually get into intramuscular spaces there, and they still have lots of weight on them that you wouldn't think that you're going into IM. If you're injecting the insulin into a patient using a safety needle tip, make sure that you only push hard enough to hear the click. And skin lifts are generally not required, only in extremely thin or children. And the skin lift involves only lifting the dermis and not the muscle underneath, which means your fingers have to actually get kind of close together, which is a risk now of a needle stick injury to yourself. So if you put your fingers wide apart and try to pull up, the muscle actually comes with it. And so you're not doing a skin lift at all at that point. But sometimes people are a little more fluffy than others, and it's harder. You have to push deeper in order to get to some firm skin under. So you can not pinch, but if you stretch the skin out, it can provide a bit of a scaffolding or a base for that safety needle tip to engage in the click on there. So this is an interesting CT scan of the thigh, which demonstrates they actually had two needles going in for the CT. One was an insulin pen needle and one was a syringe. And you can see that when they pushed in deeply, they deployed or depressed and moved away the interstitial fluid in the subcutaneous area and could get close to muscle. So we really need to be sure, especially when we're using thigh or in someone very thin, that we are not pushing too deep. So what's the big deal? So if they push harder than necessary, why does it matter if we inject into intramuscular? The problem is that the muscles have much more blood vessels in them, and those blood vessels are what pick up the insulin and carry it into the bloodstream. Of course, they're almost directly in there. And this means that if you are giving, this is an example of NPH insulin. So if you give this subcutaneously, the time action profile of getting in within about 1 to 3 hours after the injection, peaking in about 5 to 8 hours, and gone in about 18 to 20 typically, that is the time action profile we expect in a subcutaneous tissue. But if I push that into the intramuscular area, it actually turns into humulin R. Look how quickly it gets in. It's peaking in 2 to 4 hours, and it's getting gone within about 10 hours or so. So you're changing the time action profile of the insulin by injecting into intramuscular tissue. And the intramuscular uptake of insulin is 30% faster than it is in subcutaneous tissue. So volume, how much is too much? Whenever we're getting into injections above 50 units, we may want to split that. But I want to use this especially for provinces other than BC, which are, they have access to some of the concentrated insulins. They may have a U200, a U300 availability of insulin in Toujeo, Tresiba, some of the concentrated humalogs, which we don't have access to here. And so I want to go by volume. So if you're using a U100, it means that for every 100 units you're injecting, it's 1 ml. And 1 ml is too much insulin to put in at one point in time. It's too much volume for the subcutaneous tissue to handle. But if you're using a concentrated insulin like Toujeo, which is U300, which means it's for every 100 units you're injecting, it's only 1/3 of a ml of insulin, you can safely put that 100 units in, right? So the larger the dose, the more the delayed the action of NPH or the R's and Torontos and rapid acting. So the more volume you put in, the more it is not all uptaken, and it can delay the time action profile. And we may want to split some of these doses when we're getting into these higher volumes. And also, it's not very comfortable. There's more leakage and potentially more discomfort of putting a large volume in such a small space. So the time action profile, though, of the longer acting analogs like glargine U100, glargine U300, degludec, detamir, it doesn't seem to be affected by the volume of injection. It's only the NPH, the Rs and Torontos, and rapid acting insulins that have that issue. So where can we inject? So anywhere in the belly, apart from if you put your fist on your belly button, don't inject in where the fist is. But there's a lot of real estate in there, anywhere where there's some chunky monkeys. So above the belly button, below, to the side. Pregnant women inject in the side of their bellies all the time. We can go into the chunky monkeys on the hip, and we can use the thigh. I would say this picture, it's a little bit too much on the front of the thigh. It should be in the subcutaneous tissue more to the side. And the back of the arm, which really is challenging to give to yourself. So that's a site we often give when they're in hospital, and it gives the belly a bit of a break. So a guide to good rotation. It doesn't matter how they choose to rotate. They can rotate in a big circle or in 4 small circles in quadrants. They can go in an S, in an X. They can go to the back of their, put the long acting in the hips and the love handles, and they can put their rapid acting in the belly. It doesn't matter what they do, but each injection should be at least 1 centimeter apart from the previous injection, which is pretty hard to find where the previous injection was. So it's pretty good to try to choose sides or quadrants when we're doing these so that there isn't repeated injections in the same place. So they should be encouraged to use as many sites and zones as possible, and healthcare providers should verify that rotation schemes are being followed, especially if they're in an outpatient diabetes clinic or inpatient diabetes nurse for certain. So the reuse recipe for lipohypertrophy is the reminder to use a pen needle only once. At home, they have the option to reuse their needle. Remember, I told you that insulin acts like a growth hormone, and when you keep sharing that same spot over and over again, it's an injury, and bathing the site with insulin, the adipocytes grow those hard fat globules in there, and it almost is similar to scar tissue. And so it doesn't allow for any healing when we go into the same place all the time. And reuse of the pen needles can increase the degree of injury to the site, because if they use the same needle, it's getting more dull each time they use that needle. One of the advice that we use is, we know patients reuse their needles, and we know that it's a financial consideration most of the time. They should not use their needle, that same needle, more than 4 times. They should recap it, which is, again, not a safe thing to do, but is done in between so it doesn't get contaminated. Of course, never sharing that needle with anybody else, and throwing it out after the 4th use for sure. Or they could use 1 needle for their rapid acting during the day, and that's 3 injections, and then maybe for 3 nights in a row they use it for their long acting insulin. And this is a visual of when you reuse the needle. This is just a needle that has been used twice. So you can see how gnarled the point, the bevel, gets, and that it just is not as smooth an entrance into the skin. So when we want to troubleshoot as to what's going on with their glucose levels, 1 pen and 1 patient, never share an insulin pen. That can't be emphasized enough, is that you cannot share that, just like we used to share vials way back when and put a new syringe in it. We cannot share insulin pens because it's a through and through, where the blood and tissue, interstitial fluid, can come back up through the pen into the actual insulin, and it can actually contaminate the entire vial there, cartridge. Using the proper needle length, so 4 to 6 millimeters, using the needle only once, rotating the sites, and do not inject into lipohypertrophy or into muscle. And GLP-1 receptor agonist, Ozempic, Mounjaro, Zepbound, Wegovy, all of the other obesity-related ones, they're not insulin, so they don't have the same risk of creating lipohypertrophy, but they can be put in exactly the same places that insulin can be put. And because they're only injecting once a week, much less chance of any issues there as well. So the key messages are that it's not necessary to use a needle any longer than 6 millimeters. The old adage of, the heavier they are, the longer the needle we need has been debunked. The skin is no thicker than 2 millimeters thick in any person, which means that we only need a 4 millimeter needle to get under the skin. We don't need to have 13 millimeter needles going down deeper. IM injections speed up the rate of absorption up to 30% faster, which alters the time action profile. Lipohypertrophy can cause a slower rate of absorption, and in that we would increase the dose thinking that it doesn't work, that dose isn't appropriate for them, and then they have a variable glycemic response when they go to a healthy site with that higher dose. And higher volumes of insulin can impact rates of absorption and cause leakage, so we really should be splitting doses. Thank you for your attention.